Dr. Rapaport, good morning.
John, it's always a beautiful day when you come here to talk. You always ask the right questions.
Well, you make it easy.
This is a pat each other on the back session.
Well,
But we have a good time together. And I hope we're getting good information out.
I think we are. We'll talk about some of our comments we're getting in a little bit. Going through some of the feedback, all of which is just fantastic. I want to take the time to thank our viewers for. Somebody said in a comment recently that they felt like they were speaking on your behalf by reciting some of your philosophies. Hey, that's encouraged. It's wonderful. That means the word is being spread, and people are waking up to the atrocities of steroids and this farce known as eczema systematic treatments.
Well, in fact, therein is the subject that I would love to discuss this morning, if at all possible. And you're leading into it, knowingly or unknowingly. The concepts that I started writing about 35, 40 years ago and have been in print for a long, long time have been negated, blasphemed, vilified, negated, etc., etc., etc. Well, there are several of those folks in medicine, doctors, I mentioned their name and I'll mention it again if it comes up, who have plagiarized me now and are stealing my thunder and are running with the word TSW. It's their baby. Topical steroid withdrawal. And they're going to be giving lectures on it as if they've discovered it. Yeah, it's a Dr. Leo from Chicago.
You got to let that go.
So, but this leads into, okay, fine.
I mean, the fact that your work is becoming conventional wisdom. I mean, isn't that really the objective?
Well, I'm leading into the next line, which I hope it didn't come on negative with my prior line, that if I'm being plagiarized, let me at least get the facts right for them. So if they're going to plagiarize, let them plagiarize properly.
Fair enough.
Is that fair enough? Okay.
Yeah, fair enough.
Did I extricate myself?
No, you didn't get in trouble. It's just, I appreciate what you're saying.
Okay. Well, I'm entitled to be feeling heard every once in a while.
I get it.
Yeah. I know we have gone over this repeatedly, but people do forget. This is really very simple. The pathology and the physiology. It has been confused with misdiagnosis, mistreatment, and anger and hostility and arrogance. The simplicity of this is that the chronic usage of topical corticosteroids on the skin within weeks to only a few months leads to addiction, necessitating more of the steroid to conquer the new rash that is spreading and worsening, stronger strengths of the steroid because the weaker ones aren't working as well, oral steroids and sometimes intramuscular to calm down the ferocity of the rebound and flaring. That's called addiction. It's called topical steroid addiction, TSA. The vast majority of patients who need chronic usage of steroids to quell their rash are atopic dermatitis patients or eczema people. Probably somewhere between 90 and 95% of the total load of patients. The other 5 to 10% are psoriasis patients, seborrheic dermatitis patients, photodermatitis patients, contact allergy patients, an entity called Grover's disease, and a couple other miscellaneous patients who chronic itch of older age, dry skin, who chronically use steroids. They are the other almost 10%. So it is not only the eczema people. This is not bad eczema. It is addiction to steroids. And indeed, if you look at the biopsies, listen to the symptoms, observe the character of the rashes, they do not look like eczema. It's a different entity. It's called red skin syndrome. They're red from head to toe. Atopics aren't that way. Atopics do not burn. They only itch. These people are burning ferociously. It's another diagnosis. Their eczema is long gone. This is something that the medical community just cannot seem to fathom, or they don't look any deeper into the patient and see what they're telling them, what their complaints are, and what they look like. Entirely different. And obviously, the other diagnoses, once you know their history, or maybe later find out that they're psoriatics, they have a different diagnosis. They're not atopics. They're not bad eczema. Drop this bad eczema stuff. And therein, and I'll let you ask me another question. I'm sorry, but I'm getting hot under the collar. Therein lies the frailty, the fruitlessness, the flamboyance of the drug companies coming out with 5, 6, 7, 8 new drugs in the $40,000 to $80,000 a year range to cure bad eczema. They do not have eczema.
We shared a video back and forth this week about it was a woman, and the title of the video was "My 100 Days on Dupixent." The young lady in France, and I thought it was going to be a glowing review. I mean, I thought, wow, that's interesting, because it didn't indicate anything from the title. So I started watching this, and her basic conclusion was that it didn't work, and she's off. And the which doesn't surprise you, doesn't surprise me. We know that. But what was curious is that in the comments, people were ringing in with the same type of thing. I'm just getting ready to start Dupixent. What are my expectations? This and that. Nobody brought up topical steroid addiction. Not one single comment. So,
well, this leads down a couple lanes. The first lane is, are these big gun, very expensive drugs being pushed by the drug companies? And how can they not push it after they've invested millions of dollars? There are TV ads on the 6 o'clock news every night almost, though recently they've stopped, maybe because the drugs aren't working. But are they going to push, and inadvertently the doctors out there are just going to write the prescription? So one lane is, who knows what the long-term effects of these drugs are, and they're totally unnecessary, and they're for the wrong diagnosis. And the patients that were studied were not bad eczema people, they were addicted steroid people.
Well, it was interesting because this girl brings up that question. I don't know what the long-term effects of this are. And the other thing she said was that all of the references she got as to the efficacy of the drug firsthand were from people who were on the clinical trials, which I thought was curious.
The clinical trials lasted 2 months, 3 months.
Right.
Yeah, so they got a little less itch. You should see the end result, the conclusions. A little better sleep, a little less itch on the Dupixent. And the FDA approved that, and we'll get into that fiasco later on, of how the agencies are in cahoots with the drug companies. And the patients suffer. You interrupted me. I thought that not only are we worried about the long-term effects of these drugs, unnecessarily given, and just because it's new, and because she has a little rash here or a little slobber dermatitis, does not mean that you put them on a big gun drug. This needs the judgment, the proper judgment of the doctor.
Yep.
I must go backwards a little bit and try to inform everybody again and again and again that of the now probably 7,300, 7,400 patients cured, no rash, no creams, no doctors, cured, 75% were treated with support. Antihistamines, sleep meds, anti-burning meds, hand-holding, baths, psychological input, sun when appropriate, etc., etc., and they were cured with just support. Only 25% were that bad that I had to use cyclosporin. Most of them were failures on Dupixent. So not that now I brought you full circle, the failures on Dupixent probably now about 700 I've seen. I have records on all of them. And within a few days to 1 to 2 weeks, the cyclosporin was like a charm and they were clearing. What probably happened when they were on the Dupixent was either they used more steroids to calm everything down, so it tided them through many weeks, or they stopped the steroids and the addiction phase ceased for a moment and they went on a honeymoon, or I have no grand explanation. Surely the Dupixent didn't do very much. And most of the patients will tell you, wow, I was on it for 6 months, 8 months, 12 months. My doctor still wanted me to be on it. They got to give it more time. What kind of drug needs more time? Either it works or it doesn't work.
Well, two things. One, it just stuns me that a trial could even take place by scientists and physicians who don't recognize the notion of topical steroid addiction. How do you study the efficacy of Dupixent if you don't acknowledge that topical steroid addiction is a real thing?
They absolutely refuse to
honor that. So then what? So what are we doing?
Then I impugn them, I castigate them, I belittle them for entering their patients who have faith in them into drug studies where they're promising them that they'll be better off, that they're brand new, exciting new drugs. And all of them have turned out valueless, and they knew it from the preclinical trials. And the studies were only 2, 3, or 4 months. How can you get really good data in such a short period of time when I'm telling you that these patients need 3 to 5 years to be cured? It's outland. It really is. It's a comedy what they have perpetrated. And my impugning of the doctors is that not only do they sacrifice their patients, but they got huge stipends for watching them and carefully delineating with check marks every couple of weeks how good their sleep was or how it was better.
And not to be cynical, this girl was on for 100 days. That's 4 months. That's a nice little payday for a pharmaceutical company.
Sure. I'm sure I've done lots of research studies when I was at UCLA, lots of drug studies, lots of things that I believed in from the data I saw. I would never go near anything that was faulty. And the stipends then, 30 years ago, 20 years ago, 15 years ago, then it could be $1,000 a patient. I'm sure they're in the $3,000, $4,000, $5,000, $6,000.
What are you talking about? Direct payments to the physician?
Direct payments to the doctor for observing the patient. Yeah.
For doing what? Observing patients.
They're putting their patient into the drug study, signing them on, talking them into it. Everything is signed legally, and then the company is paying them for the use of their talents and their use of their patient to be on this drug trial, period, called guinea pig.
So something that came up in this video, and the video that we were watching, and in the comments, and I'd never heard it before, and I'm going to ask you if you've heard this, that the Dupixent injection is specifically painful, more so than other forms of injections. Have you heard this?
I've not
I haven't either.
No.
And I was curious. I was curious as what that was all about.
I'm not sure. When things hurt or the shot, the needle have gotten smaller. Unless this, I don't know what Dupixent looks like. If it's thick, it might need a wider gauge needle. So that hurts in itself. Sometimes the material has some alcohol or something else in it to emulsify it, and that can burn when it goes in. Things like that. I'm sure that attempts are made not to cause any pain to the patient.
Sure.
but I've not heard that. People can run the range of, oh, I'm tough, nothing happened, or oh, that hurt so badly. It's so hard to gauge sometimes.
We're already at 15 minutes. How the hell did we get there?
Well, there's a lot of information, and I never got into TSW yet.
All right, we'll tell you what. Let's do that on the next one.
Okay.
So in the meantime, please like, share, subscribe. Our subscriber count continues to rise. You're spreading the word, and it's appreciated. Send these videos to your loved ones, and let's just keep on plugging on. Thank you, Dr. Rapaport.